Hi, everyone, and welcome to this really different kind of a session at EuroPCR, talking about novel imaging techniques, imagining what inflammation might mean for our patients, and if I can't stent it, should I care? I hope you care. Stenting just takes care of a little bit of that patient's artery, and the rest of it is up to us to make sure that we save their lives, improve their health outcomes, etc. And I think that whole piece is incredibly important. It's important for you to note that this symposium, and for all of you online, thank you for being online with us, is sponsored by Novo Nordisk, and there are important disclaimers that you should take note of. Please mute your lines and your phones, and let's pay attention. This is going to be a really great session. I have the pleasure and the honor of being with this incredible faculty here with me today. We are going to be talking about really important topics, but also through real life cases, true cases that we took care of these patients in the cath lab and what to do. And with me is Professor Antoniadis from University of Oxford, a brilliant mind who has done so much work on this particular arena through imaging. I have with me Professor Capodanno from Catania in Italy, and he is going to share with us a real-world case with imaging, etc., and what he did and how he plans to care for that patient that he didn't stent, or maybe he did. He certainly images, and they're through the imaging. And a fantastic opportunity for all of you to meet for the very first time a brilliant woman, Dr. Brittany Weber, who is from Harvard at the Brigham and Women's Hospital, professor. I know you're not there yet, but you will be, professor, if not already there. But her field is cardiorheumatology. There really is. She's a cardiologist who actually absolutely is focusing on rheumatologic diseases and the cardiovascular issues that come up with these patients. That is absolutely very prevalent, and she has a lot of experience in this. So most importantly, make sure you complete your evaluation. And I want to talk to you all today. This is an interactive session, and I want you guys to get on your phones and send me questions, because I will answer. We will make sure that this group answers each and every one of your questions. You see the agenda here. We're going to talk about a little bit about atherosclerosis. Don't worry, I won't bore you. I think all of you know how it's developed. But really understanding a little bit about inflammation and where we are. But importantly, we will have Dr. Antoniadis care and tell us about the silent athero-inflammation, and then a couple of clinical cases and a lot of discussion between us. So go to Slido, enter this password, send me the questions. I really want to see your questions. I'll leave that up. This is really going to be intriguing and important. Otherwise, you can imagine, and we're doing clinical trials now in this arena. Lots of them already well enrolled, one of them in acute MI patients, and I'll talk to you a little bit about that. So let's begin with atherosclerosis. This is why we're all here. Important for you to note my disclosures. What I'll do in the next 10 minutes or so is talk to you a little bit about the role of inflammation in atherosclerosis and plaque instability. Obviously, in the setting of an acute MI, we are very concerned about this, but can we deal with the other non-culprit vessels, and even with improving and enhancing our ability to avert heart attacks down the line? That's a possibility, and that's going to be really interesting. And then, of course, some of this ideas about the biological mechanisms of perivascular adipose tissue. You know, it might even be good for all of us, for our own health, to better understand this, and maybe we could take better care of ourselves. I've learned so much about this, and I'm actually going to have one of those CTs to make sure I don't have any of that perivascular adipose tissue that could possibly be inflamed. So Atherosclerosis, all of us know the idea of the adhesion of leukocytes, activated endothelial cells, migrating and coming in into the intima, the plaque forming, the foam cells, cholesterol crystals, and of course the apoptotic bodies that then lead to this very important thin fibrous cap that could then rupture and, of course, cause clot formation, STEMI, non-STEMI, and maybe even other issues that we, unstable plaque. And I think over the years, over the last 40 years, we've done nothing but to try to do whatever it is we can do to reduce the cardiovascular disease morbidity mortality. The biggest reduction of all of this comes from the work that has been done. I often give Cindy Grimes, because she is a woman, of course, a lot of credit for primary angioplasty. That is an arena where we started to see a dip. And it certainly in the setting of STEMI, non-STEMI, PCI has been tremendously helpful in reducing morbidity, mortality of cardiovascular disease. But you could see where we are. The curve is flattening out, and there is residual events that continue to come. And the idea of inflammation is not one that just popped up in the last few years. It's been around since as early as 1943, where in an acute myocardial infarction, the sedimentation rate, fibrinogen, and very important C-reactive protein was actually noted to be elevated in some of these patients. And the very first report of this came from Dr. Irving Krupp in talking about C-reactive protein in coronary artery disease, which was published in the Proceedings of the Virchow Medical Society of my city of New York. So something to be proud of. All of us are very, very, very much, and we should be thinking about the traditional risk factors, especially, of course, hypertension, diabetes. These are important modifiable ones: diet, lifestyle, smoking. It is not to be forgotten about. And then, of course, it's the non-modifiable, that genetic predisposition, age. And of course, nowadays, as we must keep the traditional risk factors in our minds and in our hearts and caring for these patients, there's this emerging inflammation as one of the risk factors that needs to be further evaluated. We see that despite doing the very best, if inflammation is there, and I'll show you some evidence of that, that it could very well be the driver of cardiovascular morbidity mortality. And here's the data coming from our colleague, Dr. Paul Ritker, who has spent the last 2 decades thinking about this. His work and you take a look at this. This is data from large numbers of clinical trials looking at, is it enough to get that LDL low? And what if you get the LDL low, but inflammation persists in those patients? And it looks like when you have high inflammation, regardless of the level of the cholesterol, you have higher rates of major adverse cardiovascular events. This is the reality, and this is absolutely there. And by the way, we just recently, in our own database, which has been around for the last 25 years, set up at Mount Sinai, every single patient in a database. And believe it or not, 20 years ago, we've been thinking about Lp(a), C-reactive protein, and every single one of and their LDL cholesterol, and every single patient before going to the cath lab gets those biomarkers, and we follow all these patients out to a year. This was just published in the European Heart Journal. We looked at over 15,000 patients undergoing PCI, and this was for non-MI patients, but on statins. Now, take a look at this. We were able to see patients who still had residual cholesterol risk, meaning elevated LDL, residual inflammatory risk, elevated C-reactive protein, and those patients who came with a combined residual cholesterol and inflammatory risk, both of those being elevated, and those without. And you could see, look at the prevalence on top. about 25% of our patients, over 3,800 of those 15,000 patients, had both an elevated cholesterol and C-reactive protein at the time when they're having stable coronary artery disease evaluation and having a PCI. Now, what are we doing, guys? Why aren't we getting those things taken care of? And the fact of the matter is that residual inflammatory risk, cholesterol and inflammatory risk, about 3/4 of these patients are still not at goal for any of those things, especially for their cholesterol. But take a look at the major adverse cardiovascular events and the important relationship out to a year, and you start to see that the curves begin diverging after 6 months. So the stent takes care of the first 6 months events, but down the line, the residual risk, whether it's cholesterol, inflammatory, but importantly, the combined risk has a very important correlation with all-cause death, spontaneous MI, and stroke at 1 year after PCI. This is important. It isn't just about stenting. We've got to be thinking about that. And the concept of inflammation, especially in myocardial infarction, is one that to me is the most intriguing. We know that there is this low-grade residual inflammation that I just talked about, but that acute burst at the time of myocardial infarction, can we address by looking at those patients? Every single one of the patients who come in most likely will have, we call it an acute phase reactant, but there is an acute burst of inflammation when a plaque ruptures. We know that, we understand it. And IL-6 is the big driver. It's the one that we see and we can measure. And of course, the one that we often measure is C-reactive protein, because it's the IL-6 right before going into the liver and the liver producing that as a biomarker that we are looking at C-reactive protein. The idea of the fact that these two inflammatory components, the low-grade residual chronic risk of inflammation on top of that acute burst, could have an important atheroprogression, elevated infarct size, adverse remodeling, especially for that acute burst of inflammation, and of course recurrent major cardiovascular events. I think this is very, very important piece. And imagining, can we do something about this? There's a lot of evidence that this is what's going on. And the thought about getting to the acute MI early on, but remember also, inflammation is part of the healing process too. So there has to be a little bit of a balance, right? We wouldn't want to be doing something that takes away from the healing process. So we really are thinking about that. And you're going to see this over and over again. The inflammasome, these cytokines, and the activation of that in inflammation. And I think this is incredibly important. And now lots and lots of treatments that we have seen. We saw the colchicine in the microtubular as a microtubular polymerization inhibitors, as well as IL-6 inhibition that is now under investigation with ziltivekimab in Zeus, Hermes, and Artemis. And we've seen the proven efficacy for IL-1 inhibition in CANTOS. Quickly going over these two trials, two colchicine trials being positive, reduction of important cardiovascular events in the setting of MI and stable CAD. And then the big trial, the STEMI trials, I would call it mostly STEMI, 95% of these patients were STEMI. Completely negative, large trial from the OASIS investigators. And you see that this is OASIS 9 trial, showing no benefit at all. The European Society of Cardiology gives it a 2B level of evidence A for low-dose colchicine. This is, and our most updated ACC-AHA guidelines after the publication of Synergy does give you this to be, in other words, you could consider it. Of course, it's only one trial that's negative, two that were positive. The truth is in CANTOS, if you had a high elevated IL-6, this was with the IL-1 inhibition, if the patients had elevated IL-6, they had a worse outcome. And that makes you imagine that that possibly could be a target that we could get into early during the ischemic insult, imagining that we could have an important remodeling effect and then a chronic phase to deal with that smoldering inflammation. And it is for this reason that we, working together with Novo Nordisk and with DCRI, the Duke Cardiovascular Research Institute, have undertaken this massive trial. 10,000 patients presenting with STEMI or non-STEMI, undergoing PCI, will be evaluated early on in that early phase of presentation. They get a loading dose of subcutaneous 30 milligrams ziltivekimab versus placebo, and then they go home with a monthly injection of 15 milligrams Q monthly, and we follow them up until we have enough events for that primary 3-point MACE of cardiovascular death, non-fatal MI, and non-fatal stroke. We're very, very excited. We're almost 5,000 patients enrolled. Europe has been amazing in enrolling patients. How many of you are Artemis investigators in this trial? Thank you for your enrollment, and we look forward to this. I'll just quickly go over this biological mechanisms, the perivascular fat. I want you to pay attention. I'm setting the stage for our next speech. The role of adipose tissue should not be underestimated. This is obviously there is the endocrine signaling, the paracrine signaling, and now the vasocrine signaling that we need to imagine. And the idea of where is this tissue located and who's working on this perivascular surrounding the vessels for arteries greater than 2 centimeters, extending up to 2 centimeters from the vessel wall. This is where we could actually measure inflammation, not just in of course, you could have it in subcutaneous, visceral, I certainly have many of that, thoracic, epicardial, pericardial, but it's this perivascular one that I'm really, really interested in. And I can't wait for us to listen to Professor Antoniadis for what he has done and how he's classifying patients in terms of their inflammatory risk. Professor Antoniadis.
Thank you, Roxana, for the introduction. You set the scene very nicely. We hear about IL this, IL that, CRP, etc. But the bottom line is how can we find the inflammation in the coronary arteries? And that's the big question. These are my disclosures. Probably the most significant one is that I'm founder of Carizo Diagnostics, which is an Oxford spin-out company commercializing relevant technologies. Now, as interventionalists, you are very much used to try to find the patients with significant obstructive disease, stent these lesions, and then we have the ischemia trial saying that actually that may not prolong outcomes in a way that we would hope to. But now we know, and this is a fact, that many heart attacks happen when these intermediate small lesions rupture. And when do these small lesions rupture? They rupture when they are inflamed. You may have a tiny plaque, and that if it's inflamed, it may give you the same heart attack. And actually, it's more likely that to be fatal because it's the first interaction that the patient has with the beast. Now, the question is, how common is this phenomenon? From the orphan study, this is a study that we published in The Lancet a few months ago, of 40,000 patients having coronary CT angiograms, we found that despite the fact that although 18% of these patients had obstructive disease, 2/3 of the heart attacks happened in those without obstructive plaques. And this means that if you, David, go and chase those patients who have the obstructive plaques, you miss 2/3 of the events. So that's something that we need to keep in mind. If we are able to detect the inflamed artery, we can predict which artery will give a plaque. If we identify the inflamed plaque, we will identify the plaque that will rupture. And we have all seen the results of the PREVENT trial, showing that if you use intravascular imaging to identify the high-risk plaques, then you can improve outcomes because you can stent non-obstructive lesions. But we have also non-invasive tests, particularly coronary CT angiography, that gives us this qualitative but also quantitative metrics of coronary inflammation, and it allows us to find plaques that are calcified or non-calcified. However, a non-calcified plaque is not necessarily inflamed and may not be of high risk. And we need to keep this in mind because it may be organized, fibrous, and it will not rupture. Only if you do intravascular imaging, you can figure out if it's a thin cap, etc. Now, over the last 15 years in my group, we were focused on trying to find the inflamed artery. And we studied a lot of interaction between perivascular fat and the vascular wall. Our vessels are surrounded by this layer of fat. If now we have a vessel that is inflamed, this secretes inflammatory molecules that diffuse to the perivascular space from the vessel to the fat now, and the fat senses the signals, activates lipolysis, and you get this change in the composition of perivascular fat. This is in response to vascular inflammation. This is not an effect of the fat on the vessel, it's an effect of the vessel on the fat. This happens before you have the plaque, and you can predict in that way, if you can get a biopsy of the fat there, you can predict which artery will give a plaque later, and if there is a plaque, you can predict which plaque will rupture. However, we cannot open the chest of our patients and get biopsies. And this is why we focused a lot on coronary CT angiography. Normally you get these black and white images, but in these images you don't see fat because fat is an artifact and is suppressed, is removed from the images. And that's in order to get beautiful pictures of the lumen. Now, we develop a method that is called fat attenuation indexing that brings this information to the surface from routine coronary CT angiograms. If you have this yellow color, it means the artery is not inflamed. If you have these changes in the perivascular fat, then this is captured with the red color. If now you have the blue, I'll say blue is death. Blue is necrotic fat that has been completely disappeared from the perivascular space, replaced by a mushy juice from our biopsies. Essentially, this is water. Now, can this quantification of these changes with the fat attenuation index identify the inflamed plaques? So in Oxford, we are lucky to have this cath lab that essentially is linked with the photon counting CT scanner. The table of the cath lab slides into the scanner, and then we can perform imaging of plaques even during primary PCI, during an acute event. And this is one of these cases. This is a lead-presenting STEMI, and you can see how the culprit lesion lights up as red because it's highly inflamed before we disrupt it with a stent. And this is one of the pieces of evidence that we use to build up this story. And if you try to find the culprit lesions, the unstable plaques, with this method you get an AUC of 0.91 compared to intravascular imaging. And of course, you have these kind of cases that they appear late, this is a late presenting STEMI. You see that there are multiple lesions. Which do you think is a culprit lesion in this late presenting STEMI? Is the one that has all this red. This is the circumflex. With late iodine enhancement of the myocardium, we have seen that indeed it's the lateral wall that suffered from this event. So it can be used to identify the culprit lesions as well. Now, from a basic science point of view, in post-mortem studies, we know that CD68 macrophages infiltration of the vascular wall is picked up very nicely by quantifying the fat attenuation index in post-mortem CT. And then when we transfer this into a clinical setting, in the CRISP CT study, we applied it in 4,000 patients, 2,000 from Cleveland Clinic, 2,000 from Germany, from Erlangen, followed up for a decade, and we found that if you have inflammation of your coronary arteries, independently from whether you have calcified plaques, non-calcified plaques, or any risk factors, you have 5 to 9 times higher risk to die from a cardiac event over the next 10 years. So this is a massive hazard ratio. Of course, when you publish a paper like that, there is a lot of doubt. Say, is it a one-off? Is it one paper, one cohort? Is it something specific about the CRISP study? So we put together this massive study. It's the world's largest coronary CT angiogram outcome study. At the moment, we have 175,000 patients. It's the orphan study, followed up for 3 to 15 years after they had a coronary CT angiogram. and are followed up until the end of their life. We published the pilot data from this study, looking into the predictive value of this phi score in the UK population. And this is the result, published a few months ago in the Lancet. So you see that whether you don't have obstructive CAD or whether you have obstructive CAD, you can very nicely identify the patients who are at risk to have a fatal cardiac event. And we're talking about a hazard ratio of 10 if you don't have an obstructive disease, a hazard ratio of 5 if you have obstructive disease because you are already heavily medicated with statins, but there is still residual risk that can be addressed with biologics and other treatments. Now, how about the inflammation in the absence of plaque? So in the same study, we have looked into the coronary arteries of people who don't have visible plaque. You don't have heart attacks if you don't have plaques, right? Well, actually you do. And this is, you identify a group of patients, the ones on the red line, that have heart attacks in the absence of visible plaque. And these are possibly erosions. How do we know it's erosions? In our post-mortem studies, all these patients who died while they had high inflammation in the coronary arteries and they died from a cardiac event, in the absence of visible plaque, they have this red color inside the wall. This is on lipid. This is lipids essentially. This is oil redox staining for those who know histology, and this means that you can pick up the fatty streaks before they give a plaque if you measure inflammation in the perivascular fat. When you combine it with plaque, this is a very powerful tool to identify the patients who are at risk to have cardiac events. And the question that all of you have now is, okay, you find the inflamed artery, how can I treat these patients? Statins are extremely effective. They reduce inflammation by 30% in all coronary arteries in 1 year, and then this is sustained over 3 years at least. After an MI, after a STEMI, you see a striking reduction with the standard aggressive statin treatment. A recent randomized clinical trial on a biologic that targets oxidized LDL has shown a striking reduction of inflammation in all 3 coronary arteries, even within 12 weeks. And this is the only imaging biomarker that changes within 12 weeks, while if you are looking into plaque stabilization, that takes at least 18 months, 12 to 18 months. And of course, all the biologics that have been tested so far, like anti-TNF-alpha, anti-IL-12, 23, and the IL-17, they all give good responsiveness of the coronary arteries to coronary inflammation. So to put everything into perspective, when we have patients going to the CT scanner for an angiogram, we get 15% approximately with significant stenosis. These are your standard customers, guys. You have another 5% that you have to investigate whether this is a hemodynamically significant lesion. You do FFR CT if you are a fan of the non-invasive methods, or take them to the cath lab and do a standard invasive FFR. But then there is a 40% of the patients who have minor plaque. Some of us treat these patients with statins. Some others, they are reluctant. They say, this is a little bit calcified. It may not be relevant. And there is a 40% where all of you will agree that we have to send these patients home because they have 0 plaque, 0 calcium, they're healthy. Well, that's not exactly the case based on what I have just presented you. So measuring inflammation in combination with everything else is very important. Now, we talk about stenosis, qualitative plaque assessment, quantitative plaque assessment. Brittany will tell us that risk factors are very important, that we need to take into account. I told you about inflammation, but as clinicians, we act upon risk, and we are very confused. So how do you take all of this into account? How do you decide who is a patient that needs treatment and what treatment? Well, that's exactly where AI comes to help us, and does the thinking for us and the integration of all these different pieces of information together. And this is exactly the model that we develop, where it takes CT angiograms, extracts information about plaque, about inflammation, takes into account the risk factors, and gives you the absolute risk of the patient for a cardiac event. Then the guidelines tell us exactly what to do, even without the new drugs coming into play, on on the basis of risk. The model was trained originally in the US population, in the Cleveland Clinic, then it was validated in Europe, in Germany, and then as a locked medical device, it came for evaluation in the UK. And you will see that a locked algorithm evaluated in a different continent gave an area under the curve for predicting the hardest of the endpoints, which is fatal cardiac event, of 0.84. Now, if you look in our recent orphan publication, we published this graph, which is very interesting because these are not real events. These are predicted events by the AI system, stratifying patients into the 3 risk categories, which the guidelines define as the thresholds for starting statin treatment or escalating and adding colchicine and additional treatments. And the prediction was that we're going to have these events in these patients. Then we opened the labels and we evaluated the true events. And the solid lines are the true observed events. So nearly every single predicted event really happened in the time that was predicted that was going to happen. This is the power of AI. Then we looked into patients with obstructive disease. These are the ones that end up to the cath lab after they have the scan. And the result was interesting. These are the predicted events. It predicted a lot more events, as you would expect. But then when we opened the labels, there was a perfect alignment of the high-risk population. But then this middle graph, the orange, seems that it has less events than the ones predicted. Why did this happen? These are the patients that after the prediction was made, went to the cath lab, and these are exactly the patients who had the PCI. So it seems that with PCI and the treatments around the PCI, dual-platelet therapy, for example, you suppress the risk, and then after a few years, when you stop dual-platelet therapy, it picks up and comes to exactly where it was predicted originally. This is exactly the interesting area, and it's the same appearance that you have in the PREVENT study, in the treatment group. Adding quantitative plaque assessment adds very little on top of this approach. What do you do with risk? Statins that reduce risk by 30%, maintained over 3 years, and this is exactly the risk reduction we observed in the randomized clinical trials over the years. With other biologics, you see exactly the same reduction of risk, and you can predict the effect size of your randomized clinical trial when you are planning a phase 3 trial. In the UK, this is being used in a pilot program in the NHS, and it seems that it changes the management in 45% of the patients, either by starting statin, increasing the dose, of adding colchicine. A health economic study within the NHS has shown that we have an ICER of £1,300 if this is implemented across the whole NHS, which is way below the £20,000 threshold that NICE mandates as a cost-effective intervention. And we expect to have approximately 30% reduction of MACE if this kind of guided, targeted implementation of this technology is applied across the NHS. Just to summarize, coronary inflammation drives atherosclerosis and plaque rupture events. We can detect it with CT. Phi score changes dynamically with treatments, statins, and biologics. And of course, use of Phi score to guide PCI or non-obstructive lesions, which are highly inflamed, is an issue that we can discuss later. But I think it's very likely that we will end up there soon. Thank you.
Thank you so much. I urge you to send your questions, and we'll do this. But do you know if you have some perivascular influence? Did you get scanned? For you?
I cannot tell you.
Okay.
This is a secret.
I think we all want to get scanned. I don't want to lose any time. I'm trying to see if there's any questions. Have you guys, anyone sent any questions? Okay. It says, as interventionalists, we're used to fixing problems that we see. How do we build confidence in treating invisible diseases? with inflammatory drivers.
So the best way to treat invisible diseases is to make them visible, right? And then what I have shown you is how
made it
you
visible.
can make an invisible inflammatory plaque or inflammatory area of a normal vessel visible. And then you treat.
And one of the really good questions here also is, and I 100% agree, so you could make that invisible disease visible by looking at the perivascular fat and of course the C-reactive protein and the biomarkers. But the couple of other things, the questions that I think is very, very timely is that, are we underestimating the risk in patients with non-obstructive disease but elevated perivascular inflammation? And your risk score tells us we are. If we don't have that, we are not really evaluating the risk in the way we should be. And then do we think new protocols or decision pathways for cases where plaque is non-obstructive but inflamed? Do we have a case now to actually have new protocols, new decision pathways in these things?
So such a decision pathway is already implemented in the NHS in the UK, in the first 5 hospitals, in a pilot program. And this is exactly the figure I've shown you. This is a result from the new pathway. I haven't shown you the pathway, how the decision changes, but it changes in 45% of the patients.
So I guess what we're all looking for is using this as a pathway for prospective risk and prospective algorithms and showing that we could actually make an impact. And that's really sort of the future, and I can't wait for it to come. And now Professor Capodanno will take us through some cases.
So thank you. That was so inspiring. But while I was watching this presentation, I was thinking to my situation in Catania, where I don't have even a photon counting CT. I have OCT, so I felt, okay, we are sophisticated. But now that I see, of course, the vascular inflammation, I realized that we missed part of the story. So we go down to earth for a second and we watch a real case and what we miss when we feel that we have done enough. So it's a very simple case from the procedural standpoint, let's say, but it's a complex case. I realize more and more in terms of biomarkers and how the patient is. So former smoker, hypertension, dyslipidemia, obese, 62-year-old man with new onset exertional angina. So this patient had a stent in the context of a prior MI in 2007, and the medications were this one, aspirin, bisoprolol, olmesartan, and rosuvastatin 10 milligram. So, of course, EKG in this patient, there were no significant changes, some PVCs. There were no real washer abnormalities. The ejection fraction was 50%. This patient had a scan, which is something that is happening more and more because the referring physicians love to try to exclude the coronary artery disease by ruling out by means of the CCTA, but then you get more confusion than clarity sometimes. In this case, there was already a stent in this patient. We didn't know the locations, but we discovered there were 2 stents, one proximal, one distal, and there were blooming artifacts. So it was very difficult to understand what was going on in this stent. Our radiologists were able to change the gains, particularly in the proximal stent, in order to detect some areas that deserve some attention, while in the distal stent you still see this white blooming artifact. This was a bare metal stent, so it was impossible to really see what was inside. So we were stuck and there was a kind of paralysis in the decision making, and we decided to go for coronary angiography in order to decide what was the culprit lesion and the reason for the angina in this patient. So this was the invasive coronary angiography, and to our surprise, we didn't really found a striking narrowing in the stent in the proximal part. We saw that the distal stent was patent, but still we remain with some doubt. There is obviously an intermediate stenosis quite long in the mid portion where you see the diagonal, but still we were quite confused on what to do next because this patient had angina, but there are other reasons for chest pain, so we were not sure that this was the culprit lesion. So in these cases, of course, you can decide for physiology, you can decide for anatomy, and the good news is that both are absolutely okay. According to the Flavor trial, they were identical in intermediate stenosis, and we decided to start at least with the physiology, and as usual, physiology was really borderline, 0.88, 0.87. It's never really striking sometimes. We understood, and we like to do IFR pullback because it helps us, particularly in tandem stenosis, to differentiate the impact of the distal one from the proximal one. We saw the jump at the proximal one, so at least we split the problem and we divided it into two parts. The distal one was okay. The proximal one is the likely culprit in this patient. So, but 0.88, again, it's very borderline, so it was not enough. And we also needed some information, if anything, on the mechanism for the restenosis. So we started OCT because I think this is very reasonable to understand the plaque. This is the proximal boundary, and that was okay. Then we start to navigate into the stent. We start to see some narrowing, of course. Here I think it's notable findings because at 11 o'clock you see some delamination of the intima in the atherosclerosis. That is likely the mechanism here. So there is a rupture somehow. So this can be also a reason why this patient had chest pain. And when you go through the stent, particularly in the distal part, you start to see some neoatherosclerosis, I think particularly in this cross-section where you see the lipid-laden neointima between 8 o'clock and 2 o'clock. So it's very likely that this was a neoatherosclerosis, maybe in an undersized or underexpanded stent because this looks like narrow as compared with what you would expect in a proximal LAD. So this was the minimal lumen area, I would say minimal stent area in this case, and that was critical, and therefore we needed to do something. We placed a stent, so here you can discuss DCB or a stent. In the context of the restenosis of a drug-eluting stent, we prefer to place a stent, bigger area, and therefore this was needed in order to address this failure of a stent implanted in 27. So the problem is that when you have the OCT on the table, it's too tempting to give another pullback, and fortunately we did because we found a dissection at this point in the proximal part. So we had to place another stent. Otherwise, the stent was okay, well rounded, expanded, and not really malapose. So it's very important to check and optimize the result with OCT as well. So this is what we have as interventionists. We place another stent. The result was okay, and we longitudinally reconstruct the picture in order to make sure that there was no need in some parts for post-dilatation. So this is what we can do as interventionists using OCT. But the point is that the story starts now, not really because I will show some rocket science now, but in a patient like that, did we do all that we can do, essentially? No, because we have the lab panel. And this patient, remember, obese, had LDL cholesterol 82, LP Lidolay, which we are starting to dose now, because of course the evidence is accruing, 115 high. High sensitivity CRP 3.2, it's also high. And we know that the combination of these three biomarkers is additive. So you have three biomarkers that are abnormal, and the risk, the residual risk of this patient is definitely increased. So I would say that normally I would put in my chart the diagnosis of instant neoatherosclerosis in a patient 62-year-old with prior PCI, but now I realize that I need to add one line when I make my diagnosis. This is a patient with a failed stent because of neoatherosclerosis and because of a high residual atherothrombotic and inflammatory risk that was not addressed early in 2007. So that's the reason why probably we have the new event. So maybe one question, if I can involve Brittany here as a transition also to the next case. So do you think that identifying neoatherosclerosis here as the cause of this event can help us to shift from the purely mechanical perspective to something which is different, maybe?
Yeah, excellent case, because these are all real life cases that we see. And the answer is absolutely. You know, I think that Roxana gave a beautiful startup of this. And what we now know with this neoatherosclerosis, we know the role of inflammation is this really can be additive, right? To really add into addition of the importance of being able to address the biology here and the mechanism of being able to address the residual inflammatory risk.
Thank you. So let me just, Roxana, phrase what I think are the key lessons that we learn from a case like that. Remember, this is a patient with a high residual atherothrombotic and inflammatory risk, so we have really to intensify the therapies that we have, waiting for new therapies maybe in the future. So in terms of antiplatelets, not just one antiplatelet, but two, of course. We have now several layers of stents, so at least 6 months of dual antiplatelet therapy because we are in a stable CAD setting. In terms of lipids, it was okay, but not so okay. We want to go down below 55 milligram per deciliter, like the guidelines mandate. So we added ezetimibe to rosuvastatin, and we had consideration for PCSK9 inhibitors because of lipoprotein A. We don't have drugs specifically targeted that yet, but with PCSK9 inhibitors, you can downsize by 20% at least, and maybe reduce that level as well. And colchicine, this is a Lodoco 2 potential patient. We know that in the setting of a STEMI, as you said, it's really more than controversial. It's negative, but in a stable CAD patient, in recurrent events, frequent flyer patients, it's something that we still consider when the biomarkers are high. So I would say that in a case like this, we see that patients with recurrent events because of in-stent stenosis, imaging provides unique insights into the mechanism for in-stent stenosis. We like to use this pullback pressure gradient in combination sometimes with intravascular imaging, because this is something that helps us to take a decision, particularly when you have a diffuse disease like in this patient. It's crucial to optimize the result of PCI, but we are not plumbers, we are cardiologists. So we need really to address also with secondary prevention in an intensive way all the risk factors in order to reduce the residual ischemic and inflammatory risk. But then the question that transition to the next case maybe is that we need to identify the residual inflammatory risk, and this is very challenging. Maybe with the next generation imaging we will be able to do better than with OCT.
You're missing two things. First is your photon counting scanner to see inside the stent.
So we will buy immediately.
Yep.
Of course, they will not buy to us. We will ask.
And the second is a connection to get your perivascular fat analysis.
Okay.
That's great, and I love how confident you are with your data. But I also believe that our colleagues are saying, okay, we find this, now what do we do? And clear synergy was completely negative. Yeah, mostly in STEMI patients, we could consider it. What do you make of clear synergy? I mean, we can't just ignore a completely negative study. And there was a lot of diarrhea. There were issues with colchicine. Can you explain, and why are we still after inflammation when clear synergy was clearly negative?
Absolutely. I was very intrigued that the two meta-analyses of colchicine were published in the European Journal a few weeks ago, and they still see some benefit for colchicine. So it seems like clear synergy, the largest trial, is the outlier, but you cannot say it's the outlier because it's the largest study. So maybe some issues with adjudication of events. There was the pandemic, of course, during this, so this is one of the reasons. Maybe the dose of the colchicine, particularly in obese patients, there was the idea that the higher doses twice daily are better than one single dose. So it's one negative study, but Colcott was positive. So I think the jury is still out, and the meta-analysis are overall positive. So this is all that we have.
Yeah, so a quick answer to a question that came about the orphan study. Most of those outcomes were related to heart failure. How does inflammation relate to heart failure?
Oh yeah, this is a very clear answer. We answered this exactly question in a letter to the Lancet.
Yeah. Okay.
So
maybe it's the same person who's writing that.
There is maybe there is If you look into the data, there is independent prediction of MI. Full stop. That's in the supplement. And then there is independent prediction of heart failure, but only ischemic heart failure. What does it mean? It means that it's either a result of the MI or microvascular disease.
And remodeling and all of that, which leads to heart failure.
Ischemic
no,
heart failure.
I 100% agree with that. And our next question actually sets the stage for you, Brittany. What about coronary disease and rheumatic disease? So why don't we set that stage for you and let you show us, but maybe you could just tell us a little bit about rheumatic disease.
Yeah, very, very interesting question. And absolutely, this, my clinic is specialized in patients with systemic inflammatory disorders, but there is a clear interconnection because we know that inflammation drives atherosclerosis, and we know people with systemic inflammatory disorders have excess cardiovascular risk even after adjusting. And we believe that excess risk is inflammation. And there's a lot of parallels we can learn in a lot of these diseases, and we're treating inflammation in these diseases. So excellent question, and one that's exciting. So that's going to bring me to my case here. My disclaimer is I'm not an interventional cardiologist, but I send a lot of my patients to the cath lab, and I think about inflammation all the time. And so this is such a a fun opportunity to be here to be discussing this such important topic. And so I will be going through a case from our hospital today. Here are my disclosures. And here I'm going to set the stage. So this is a patient that did present to our hospital. You're going to see all the fantastic imaging, the coronary angiogram. Certain features of the cases have been adapted, but of course, this is all the typical patients we see in our clinic. So this is a 69-year-old man who comes with a past medical history of an STEMI who presents to Boston after coming from a medical town with not all of his records. How often do we see a case like that? Here was his history that he gave us. He had been medically treated for STEMI 3 years prior. He's currently asymptomatic, so that's important. Here's his blood pressure. His LDL is pretty well controlled of 46. You can see his EF on his last echo in the data and the records that we got was 50%. His A1C, you can see his BMI as well here, and you can see a normal renal function. Here was his current medical therapy. He came on a baby aspirin, rosuvastatin, bisoprolol, and enalapril, as well as evolocumab. What do we do in the clinic? Well, this is something I do in all my patients. I check it at baseline when I'm doing the standard lipid assessment. I certainly incorporate hsCRP testing, and you can see that his hsCRP was 6.8 milligrams per liter. And so what do we proceed to? A coronary CT, and you're going to see some of the images, and I'm very fortunate at our institution at the Brigham Women's to have a high-resolution photon counting CT, and what I'm showing here is beautiful images of the LAD, left circ, and RCA, and what I can hope we can all appreciate on there is the extensive multivessel disease here. And of course, I can't show you all the images in the sake of time, but I am going to show you the totality of all the data we got from this beautiful images, where we can demonstrate there was a severe stenosis of the mid to distal left circ and distal PDA. We also demonstrated moderate stenosis of the proximal circ, mid RCA, and mid LAD. So there was a mild stenosis in the left main, as well as a focal dissection flap in the mid RCA that was proximal to that area of stenosis. So I think we can all appreciate this high-risk scan and potentially what we all may be doing in the clinic when we got this report back. I do a lot of coronary CTs. Sometimes I get very high-risk reports back on a Friday night, and I'm often calling the patient. And so what did we then proceed with? Well, this basis of this, I discussed with the patient, and he agreed to at least undergo a diagnostic coronary angiography. So I'm going to show you some of these images, and I'm going to let them play in the sake of time. I think they're not going to all play together. Let's see here. There we go. What you can see here is you can see the diffuse disease in the right. I'm going to go through and show you some of the other images. Play these so they all run. So not pretty images, right? So I'm going to let you all look at all the extensive diffuse disease to think about what you may be doing at this time when we're seeing this patient in the cath lab. There's one more view here. So what do we observe? Well, again, diffuse disease, 40% mid-RCA. There was an appearance of a healed plaque there, and there was that 80% PDA lesion. There was no significant disease in the left main. You can see here that there was similar to the LAD, and the left circumflex, there was that 50%. So what will we all do at a case like this? Well, you would think about, as we heard from Davide's lecture, we would think about additional functional tests. And these were proposed to the patient, however, he declined. This is not something that infrequent, right? We can all think about our patients that actually do not want to undergo further testing. He felt fine, but he had all this high risk. And so at our institution, we referred him for multidisciplinary discussion where we all discussed the case. And here's what happened. So there was the interventionalist who proposed complex multivessel PCI as an option. However, it was long diffuse lesions, as we can all appreciate, likely requiring multiple overlapping drug-eluting stents and extensive lesion preparation. Procedure was deemed high risk due to the diffuse disease, the lesion length, the potentials for complications, and the uncertain symptomatic benefit here. However, as I just alluded to on the last slide, he declined further intervention due to the absence of symptoms, and he was concerned about the procedure risk. So what else can we do? We've been talking about residual risk and aggressive management of the risk factors. And so what can we do to continue aggressive secondary prevention in a case that we know from here is very high risk? So what next? Well, he continues to feel well without symptoms. We've been following him in clinic. We repeated an hsCRP. Again, I check this in all my patients at their baseline assessments, not when they're unwell or they're having an acute event. You can see here his HSCRP is 5.8. And so what other kind of data can we get for aggressive secondary prevention? Well, you already heard from Harris's lecture, the role of perivascular fat. And so we were fortunate to be able to get this. You saw our beautiful CT high resolution images. And wow, I want to show you this because it is very impressive. So this is the phi score. You already learned all about this morning. And just look at how inflamed our patient was. This demonstrates a phi score of extreme inflammation in the RCA, the 89th percentile. And remember the predicted risk we discussed? Look at this. The predicted risk of an 8-year risk for fatal cardiac event is more than 54%, more than 50%. I mean, look at that. So here I'm showing you. You can see here that we actually can observe here. You can look at the colors, that they're stabilized, non-inflamed, non-calcified plaque. It looks like it actually responded well to medication, and it has now achieved calcification and stability. But look here, there's the area of the extreme inflammation. Could that be a prognostic PCI target? That's kind of what we're here discussing, is the future here. And so, to take it to our panel, our esteemed panel, how would you approach the discussion of the future risk with this patient who is reluctant to undergo intervention because he feels fine? What would you do?
For me, seeing is believing. I would show this picture to the patient because
Exactly.
it speaks by itself,
Yeah.
simply.
I think the picture is worth
Yeah.
1,000 words, but I certainly would talk to him about functional testing now.
Yeah.
There is inflammation. There is that RCA looks so, it actually looks ugly. I mean, that proximal flap, even though if you could call it healed with all that inflammation, I don't think it's healed. And I certainly would want to proceed to imaging, intravascular imaging and physiology for a case like that.
If AI tells me that I have 1 in 2 chance to die in the next 8 years, I think I will start medication. Yeah.
Well, of course,
And
medication, but I
probably go
think I'm
on
wondering if by
follow-up
the time the
intervention.
medication starts to kick in, are we not going to be able to do something with that? I mean, if there is a functional significance there, I'd fix it and give medication. They can both be done.
Absolutely. And sometimes just being able to discuss with a patient with an image like that may then kind of then make the patient realize he could benefit from under functional imaging. Absolutely. And I agree. Seeing is believing. These are things that
And
we
when
can
he
discuss.
says he's feeling fine, I kind of don't believe him. You
Exactly.
can also put him on a treadmill and see how he does and how long
100%.
does he go. And
Yeah.
he's feeling fine. He's sitting in a chair.
Yep.
But maybe you get him climbing a couple of stairs with your Bruce protocol, and he's not going to be feeling fine. I just can't believe it. But let's see, what did you do?
Well, I think we're, well, for him, he is still declined because this is a case at our hospital. So he is on, the only thing we could add at this point in trials, which is on colchicine, but it's still an ongoing case because it's a recent case at our hospital. So that's
Right.
what we're doing. But to begin with, our next question is, should we begin managing inflammation as aggressively as we manage cholesterol in a high-risk patient population like this? What do you guys think?
Absolutely.
Yeah.
Yeah,
Of course.
especially if you find inflammation specifically in the coronary arteries,
Yeah.
and you have this high risk, then what else do you have to do? Yeah.
I've often seen that if I get that cholesterol really, really low, I can manage their C-reactive protein comes down.
Yeah.
But and then maybe, I don't know if you would do multiple imaging to see actually, and how long does it take,
Right.
but before you start to see that peri-adventitial, attenuation or inflammation go away, and then I guess I would think about colchicine or some kind of a treatment.
Yeah.
I wish that I had better things. I mean,
Exactly.
to be honest,
Yeah.
and I'm not so sure that how effective is colchicine there.
Exactly.
We
And the
need
question-
biologics.
Yeah.
Yeah, and this is this is what I sit and do every day is take care of patients on biologics and think about all the pathways and what next. And so we've been discussing this in the conference today. We know colchicine has proven cardiovascular risk reduction in some high cardiovascular risk populations, although studies have been conflicting. We again saw these earlier in Roxana's the first 2 trials as well as the clearly negative trial over here. And so again, would this patient benefit from anti-inflammatory therapy? I think we can all agree yes, and we can also all agree that he should undergo functional imaging and more testing. And so I showed you a very impressive fat attenuation index case today. So can this track dynamic changes, as you just alluded to, would you be re-imaging this guy? Well, this is where the future, right? So as Harris showed you in his talk today, these are three beautiful trials that showed you this. As a cardiorheumatologist, I spent a lot of my time taking care of patients with psoriasis. I also do a lot of research on this, and this was a very nice study that showed phi did decrease within 1 year of being on a biologic, and this was all TNF, anti-IL-17, IL-23, so different pathways, but showing the concept. Again, we saw the changes of phi in post-STEMI, as well as on the right here on post-statin treatment. So the early data is yes, and this is really where we need to take it into perspective, which is what was already raised. And so one more question for us to all ponder is, if stenting is not an option and there is an inflammatory driver, we've been discussing this, but how confident are you in the current therapeutic toolbox to halt or reverse the process?
Well, if I see this inflammation, of course, I need an anti-inflammatory drug. Colchicine is the only option that is approved. So I think we missed the smoking gun, that there is really an effect of a drug that targets inflammation. It works on clinical outcomes. But the good news is that we will have more to come on
We'll have
on this
more
topic.
to come. I'll tell you that a lot of my patients are worried about biologics. And as somebody who is caring for these patients, what complications are you worried about? What are you seeing? Is this IL-6 inhibition? If this thing works, should we be worried about the safety?
Excellent question. And it's not an uncommon one, right? And it's not an uncommon one at all, especially within a field of cardiology where we're not used to taking care of patients on biologics. But this is something I do every single day. I've been studying immunology and inflammation since I began my training. And the answer is, they are safe to use. So, but you also have to, just like we have to remember the caveats of blood thinners and when to not use them or when to worry, similar to biologics, we have to, anytime we're going to be targeting the immune system with a biologic, there'll be certain, scenarios for every biologic that they can't be used. Maybe somebody with a gastrointestinal issue for IL-6, they're all different for the biologics. And we have to remember the one adverse effect is increased risk of infection. That doesn't mean they're not safe and you can't use them. You just have to have the education of the patient and the other providers to alert us when they have those features, and then they can get treatment. And so that really brings me down into our roadmap. This is something I love because I think about these pathways a lot. And we do know the central role of the NLRP inflammasome. We've seen this a lot. And we can see here that there are multiple, the future, right? It's so exciting because we are now testing inhibition across this pathway, right? So we all know colchicine up here. We all know that we also may need something more potent. We have the proof of principle concept, very important IL-1 that did not further into clinical development for that indication. Although we do utilize IL-1 in other cardiovascular states and many patients with inflammatory disorders. We have phase 1 and phase 2 trials studying other pathways that are more upstream. And then, of course, we have a very important molecule, IL-6, and 3 large studies that will be testing this hypothesis, and so more to come. But we do utilize IL-6 inhibition very commonly in rheumatology, and we do know the safety of these drugs, particularly in rheumatoid arthritis, where they're used for many years. And so one more additional question as we're wrapping up the session is, could additional modalities such as the pericoronary fat provide clinically relevant insights into this case before what was beyond? So that.
And actually, to answer this.
Don't leave us yet. Yeah, just answer that, and I will have last question, and then we got to get off the stage.
Okay.
So.
To answer this, I will show a figure that is coming out in Euro Intervention in a couple of weeks. So essentially, how do you know who to treat and what to treat the patient? What to give to the patient. So if you have an artery like this, which is pristine, no plaques, no inflammation, you don't need to do anything, primary prevention. If you have an artery that is pristine with no plaque, but with high inflammation, that's when you need to really worry, but it's too early and you can intervene to prevent the heart attacks. If you have a plaque that is non-calcified and inflamed, that's a very, very high-risk patient. You need to do something about that plaque, potentially prophylactic PCI in the future if there are trials showing benefit. That plaque can either go down the route of stabilization and then calcification and no inflammation, or it may evolve into a very high-risk patient, with like a ticking bomb, that at any point will give an event, or it can even give an event straight on, and you can see this high inflammation. All these different points are points of intervention with novel biologics, and potentially there is a room for prophylactic PCI in the future, but we need trials to prove that.
No,
That's
thank
my
you
answer.
for that. And I think one last question that came up is, if you do treat these patients, does that become like a lifetime treatment for them, biologics or even colchicine, or do you wait and when the C-reactive protein goes down, can you stop it?
Yeah, no, so I would not stop it just because C-reactive protein goes down, because it should go down, right? Because you're utilizing an upstream inhibitor of CRP, so that would be an important thing that you would want to see go down in something. It's just like asking the question of a patient with rheumatoid arthritis. We put them on a biologic, they start to feel better in a couple of weeks. We don't stop the drug, right? Because we are stopping the process. So I don't think that these are short term. I think the question is, the length is still to be determined in all the trials because it's a new area, but I would not just automatically stop these either.
Well, this
Yeah.
has been a fantastic session. Thank you so much. Did you guys enjoy it? I hope so. Thank you for being here. Enjoy the rest of the meeting, and thank you all for being here. Thank you so much.